Welcome to the Deep Dive. Today, we're tackling breast cancer.
Yes, focusing on the key things you need to know.
Exactly. We know medical info can be overwhelming, so we're aiming for a clear, efficient guide. Think of this as, well, your essential revision toolkit.
Precisely. Our mission here is to pull out that core knowledge on breast cancer. We'll cover the definition, causes, risks, how it develops.
How it presents, diagnosis, treatment, the whole picture, really.
Right. We've basically distilled a set of detailed revision notes into this conversation.
So if you're looking to get a solid grasp on breast cancer, quickly but thoroughly, you're in the right spot. Let's dive in. What fundamentally is breast cancer?
Okay, so at its heart, breast cancer is a malignant growth. It's abnormal cells originating in the breast tissue itself.
Usually in the ducts or lobules, right? The milk-producing parts.
That's typically where it starts, yes. The key issue, and why it's serious, is that these cells can invade nearby tissues.
And potentially spread elsewhere in the body.
Exactly. That potential for spread, or metastasis, is what makes it a major health concern.
We have a little memory tip for that core idea, actually. Think of bad cells.
Oh.
Yeah. B for breast, A for abnormal growth, D for dividing uncontrollably. Just a quick way to, lock it in.
That's helpful. Baddie cells. I like it.
So what actually triggers this abnormal growth? What's the etiology, the underlying cause?
Well, it's usually not straightforward. It's generally seen as a complex interplay.
An interplay of what?
Of genetic factors, hormonal influences, and environmental factors, too. It's rarely just one single thing acting alone.
So more like a combination hitting.
Pretty much, yes.
Yeah.
We know genetics can play a really significant role. You've probably heard of the BRCA genes.
BRCA1 and BRCA2, yes.
Right. Mutations in those specific genes are strongly linked to a higher risk. Normally, these genes help repair DNA damage.
Sort of like the body's proofreaders?
Kind of, yeah. That prevents cells going rogue.
Yeah.
But if these genes are mutated, that repair system is faulty.
Which makes cells more likely to become cancerous.
Exactly. It increases susceptibility.
So a common question people might have is it just bad luck, or are there specific causes? If someone has, say, a BRCA mutation, does that automatically mean they'll get breast cancer?
That's a really important point. No, it's not an automatic guarantee. It significantly increases the risk, the likelihood, but it doesn't make it inevitable.
Okay.
So it's not purely chance. There are identifiable factors like these gene mutations, but also hormonal elements, lifestyle.
Yeah.
It's multifactorial.
Got it. That makes sense. Let's dig a bit deeper into those contributing factors then. What are the key risk factors we should know about?
Okay, let's break them down. Firstly, and most obviously, female gender.
Though it affects men too, just less commonly.
Much less commonly, yes. Then increasing age is a major factor. Risk goes up as you get older.
And family history.
Definitely. Having a first-degree relative, mother, sister, daughter with breast or ovarian cancer increases risk.
And tied into that are the inherited gene mutations we mentioned, BRCA1 and BRCA2.
Yes, and those carry a really significant lifetime risk. We're talking around 40% for either breast or ovarian cancer for carriers.
Wow, 40%. That's substantial. What else?
Having had breast cancer before or certain non-cancerous benign breast conditions, those can increase risk too.
Okay. And hormonal factors. You mentioned those earlier.
Right. Things related to estrogen exposure, mainly. So starting periods early, going through menopause late.
More years of hormonal cycles?
Essentially, yes.
Yeah.
Also, having your first pregnancy after age 30, using some types of hormone replacement therapy, HRT, and interestingly, not breastfeeding.
Not breastfeeding increases risk.
It seems to, yes. Breastfeeding appears to have a protective effect.
Any lifestyle factors?
Obesity is a known risk factor, particularly after menopause. And there are other less common genetic predispositions, like mutations in the P53 gene.
Right. That's quite a list. For revision, is there a way to maybe group these or remember them easily?
We can try a mnemonic. How about FABHIPNOP?
Okay, let's hear it. FABHIPNOP.
F for female, A for age, B for bloodline that covers family history, and BRCA.
FAB. Got it.
Then HIPH for hormones. Think early, late periods, pregnancy timing, HRT, not breastfeeding. For inherited genes like P53, P for previous breast issues.
FABHIP. Okay.
And NOP maybe for not breastfeeding, obesity, pregnancy over 30. It's a bit of a stretch maybe, but it pulls the key ones together.
No, I like it. FABHIPNOP. It gives you hooks to hang the information on. Okay, so we know who might be more at risk. What's actually happening inside the breast tissue when cancer develops? The pathophysiology.
So it typically kicks off in the cells lining the milk ducts or perhaps the
The
lobules.
basic building block.
Exactly. And over time, these cells accumulate genetic mutations,
Mm.
little errors in their DNA.
Which messes up their normal behavior.
Right. It disrupts the normal controls on cell growth and division, so they start multiplying uncontrollably.
Like a faulty switch stuck on.
That's a good way to think about it. And this uncontrolled growth forms a clump, a tumor.
And then it doesn't just stay put.
Not always. These cancerous cells can develop the ability to break through the normal tissue boundaries. They invade the surrounding breast tissue.
Okay.
And the bigger concern is they can get into the lymphatic system, like the body's drainage network, or into blood vessels.
Which allows them to travel.
Precisely. They can use these systems like highways to reach nearby lymph nodes, often in the armpit, or travel to distant parts of the body, lungs, liver, bones, brain. That's metastasis.
Like weeds spreading in a garden, starting small but potentially taking over if not dealt with.
That's a very good analogy, actually.
So if someone finds a lump or has a concern, it's not automatically cancer, right? How do doctors tell the difference? What else could it be? The differential diagnosis. People might ask, how do you know it's not just a normal lump?
That's a vital question because, yes, there are several common, benign, non-cancerous conditions that can mimic cancer.
Such as?
Well, you have things like fibroadenomas. They're solid, smooth lumps, very common in younger women. Then there are cysts, which are just fluid-filled sacs. Fibrocystic changes can also cause general lumpiness or tenderness, often related to hormonal cycles. Less commonly, you might see fat necrosis, which is like damaged fatty tissue forming a lump, maybe after an injury.
So a lump doesn't equal cancer?
Absolutely not. That's why proper investigation is key. You need to differentiate these benign things from a malignant, cancerous tumor.
Oh, and sometimes inflammatory breast cancer can present differently too, more like redness or swelling.
Right, requires careful checking. Before we get to the checks, how common actually is breast cancer? What's the epidemiology look like?
It's very common. In the UK, it's the most frequent cancer diagnosed. We're talking over 54,000 new cases every single year.
54,000, wow.
Yeah, and again, mostly women, but men too. And sadly, it does still cause significant mortality, over 11,000 deaths annually in the UK.
Those numbers really drive home why understanding this is so important.
They really do.
So what are the typical signs someone might notice? How does breast cancer usually present itself clinically? The most common presentation is probably finding a new lump or a thickening in the breast or armpit area that feels different from the surrounding tissue.
A distinct lump.
Yes, but it's not the only sign. Changes in the size or the shape of the breast can occur. Nipple changes are also important things, like the nipple suddenly turning inwards, becoming inverted, or having an unusual discharge, especially if it's blood-stained.
Okay, nipple changes too.
And skin changes on the breast itself. That could be dimpling, like an orange peel texture, or redness, or peeling skin.
Like the skin is being pulled or irritated.
Exactly. And finally, sometimes the first sign might be swollen lymph nodes, glands in the armpit.
So, quite a few potential red flags, not just a light. Is there a mnemonic for remembering these clinical features?
We could try lumps in skin nipple lymph.
Okay, break that down.
L for lump, U for unexplained size or shape change.
Yeah.
M for maybe marked skin changes, dimpling, redness. P for nipple problems, inversion, discharge. And S.
Swollen lymph nodes.
S for swollen lymph nodes. Perfect. Lumps in skin, nipple lymph.
Great. Another useful one for revision. So if someone notices any of these things, or maybe something shows up on screening, what happens next? What investigations are done?
Right, the diagnostic process usually starts with imaging. Mammography, that's the breast X-ray, is key for both screening asymptomatic women and investigating symptoms.
So mammograms are step one.
Often, yes. If the mammogram shows something suspicious, or if the symptoms warrant it, even if the mammogram is clear, the next step is often a breast ultrasound.
Which gives a different kind of picture.
Exactly. Ultrasound is very good at telling if a lump is solid or fluid-filled, like a cyst. Sometimes an MRI might be used, too, for more detailed images in certain situations.
But imaging alone doesn't confirm cancer, does it?
No. The definitive diagnosis comes from a tissue biopsy.
Taking a sample.
Yes, usually using a needle to take a small sample of the suspicious area. That tissue then goes to the lab to be examined under a microscope.
And that tells you for sure if it's cancer.
Yes, and crucially, it also tells us about the cancer. The biopsy results reveal the type of cancer, its grade, how aggressive the cells look, and its hormone receptor status, meaning whether it's fueled by estrogen or progesterone.
Okay.
And also its HER2 status, that's another protein involved in growth. These details are vital for planning the right treatment.
And what about genetic testing, like for BRCA? When does that come in?
That's usually considered for individuals who have a strong family history or other factors suggesting a high risk of an inherited mutation. It's not routine for everyone, but it's important for assessing future risk and sometimes guiding treatment choices.
So it's a step-by-step process. Imaging, then biopsy for confirmation and characterization. Once cancer is confirmed, what's the approach to management?
It's very much a team effort, a multidisciplinary approach. You'll have surgeons, oncologists, medical and radiation pathologists, radiologists, specialist nurses, all working together.
A whole team.
Absolutely. And the main treatment tools we use are surgery, radiation therapy, hormone therapy, biological or targeted therapy, and chemotherapy, plus ongoing surveillance.
Let's break those down. Surgery feels like a cornerstone.
It often is. Most patients are offered surgery to remove the cancer. The main exceptions might be very frail elderly patients or those where the cancer is already spread widely.
And what types of surgery?
There are two main types. Lumpectomy, also called wide local excision, where just the tumor and a margin of healthy tissue around it are removed. Or mastectomy, which is removal of the whole breast.
And the choice depends on?
Tumor size, location, whether there are multiple tumors, breast size, and importantly, patient preference. Breast reconstruction is often an option after mastectomy, either immediately or later.
Right. What about radiation therapy? When is that used?
Radiotherapy is very commonly given after lumpectomy. The goal is to destroy any tiny cancer cell remnants in the breast tissue and reduce the risk of the cancer coming back there.
So cleaning up after surgery.
Essentially, yes. It can also be used after mastectomy in certain cases, like if the tumor was large or if cancer cells were found in the lymph nodes under the arm.
Okay. Then there's hormone therapy. You mentioned that's for hormone receptor-positive cancers.
That's right. If the cancer cells have estrogen or progesterone receptors, we can use drugs to block those hormones or reduce their levels. It's like cutting off the fuel supply.
What drugs are used?
For pre- or perimenopausal women, the main drug is usually tamoxifen. For postmenopausal women, we often use drugs called aromatase inhibitors, which stop the body making estrogen.
Got it. And biological therapy, targeted drugs.
Yes, this is about targeting specific molecules involved in cancer growth. The best known example is trastuzumab, or Herceptin. It targets the HER2 protein.
So it only works for HER2 positive cancers?
Exactly. It's a very effective treatment, but only for that specific subtype.
And chemotherapy. That often sounds like the big gun.
Chemotherapy uses drugs, usually given intravenously, that travel through the bloodstream to kill cancer cells throughout the body. It can be used before surgery, that's neoadjuvant chemo, to shrink a large tumor.
Make it easier to remove.
Precisely. Or it can be used after surgery adjuvant chemo to mop up any cells that might have escaped.
When is chemo typically recommended?
The decision depends on the stage of the cancer, the grade, hormone receptor, and HER2 status, and whether lymph nodes were involved. There are scoring systems that help predict the risk of recurrence and the potential benefit of chemo. A common regimen you might hear about is FECD, but there are several others.
It all sounds very tailored to the individual.
Highly tailored, that's crucial. We also need to mention the referral process.
Right, getting people seen quickly.
Yes. There are urgent suspected cancer pathways, sometimes called 2-week wait pathways in the UK. If someone presents with those key symptoms, lump, skin changes, nipple issues, armpit lump, they should be referred urgently to a specialist breast clinic.
And for younger people.
For those under 30 with an unexplained lump, the referral might be less urgent initially, as cancer is much rarer, but they still need proper assessment, often starting with ultrasound.
So a very structured approach from suspicion to diagnosis and a personalized treatment plan. After all that, what's the general outlook? The prognosis.
It really is variable. Prognosis depends heavily on the stage at diagnosis, how early it was caught. Earlier stage means better prognosis, generally.
Makes sense.
Also, the cancer's characteristics, its grade, the receptor status we talked about, and how well it responds to treatment. But, and this is important, outcomes have improved significantly over the years.
Because of better screening and treatments?
Exactly. Early detection through screening and the advancements in surgery, radiotherapy, and drug therapies mean that many people diagnosed with breast cancer today have a very good long-term outlook. So while we need to be realistic, there's definitely a strong message of hope.
That's good to hear. Lastly, what about potential complications, things that might arise from the cancer or the treatment itself?
Well, the most serious complication of the cancer itself is metastasis. the spread to distant organs like bones, liver, lungs, or brain.
Okay.
From treatment, particularly surgery or radiotherapy involving the armpit lymph nodes, patients can develop lymphedema. That's swelling in the arm or chest due to disruption of the lymphatic drainage.
Is that common?
It can be, and it requires careful management. Other common treatment side effects include fatigue, hair loss with certain chemos, nausea, menopausal symptoms from hormone therapy.
A whole range of potential issues.
Yes, and we absolutely mustn't forget the emotional and psychological impact. A cancer diagnosis and treatment journey can be incredibly challenging mentally and emotionally. Support in that area is vital.
Definitely. It affects the whole person, not just the body.
Well, this has been incredibly thorough. We've really covered the spectrum definition, causes, risks, development, diagnosis, the different management strategies, outlook, and the potential complications.
We've tried to hit all the key points you'd need for a solid revision or understanding of breast cancer based on those initial notes. And hopefully breaking it down like this conversationally has made it clearer and more manageable than just reading dense text.
That's the aim.
For everyone listening, if you want to delve deeper or find more resources specifically for medical exams like the MSRA, do check out pastthemsra.com and freemsra.com.
They're great resources.
And just a final thought to leave you with, consider the sheer pace of change in this field. Research into breast cancer is constantly evolving new targeted therapies, better understanding of genetics, refined screening techniques. It's a dynamic area with ongoing progress.
Absolutely. The future likely holds even more personalized and effective approaches.
Indeed. Thank you so much for sharing your expertise today.
My pleasure.
And thank you all for joining us on the Deep Dive.